in today's session, we covered lower and higher risk myelodysplastic syndrome and leaned into secondary AML or mutations that might allow us to think about secondary indications. I'm going to pass on to Dr. Brunner, who's going to highlight a few of the talks that we had covered today. And what's really remarkable is that our panel of speakers are from U.S. and ex-U.S. And we have people representing different time points in their career. So we're seeing a lot of exciting new data, interpretations of the data, and what might be coming next.
Yeah, absolutely. Our first section talks a lot about low-risk MDS. So people who live with their MDS and largely have anemia as their main problem. And this is an area of MDS where there has been a lot of advancement and exciting advances in the last couple of years, including several studies that have shown positive results in the last year. And so it's an area where we're really learning how to tailor treatment to the patient and also how to think about sequencing therapies so that we can provide the most benefit for each patient for the longest period of time. So we talked today with speakers about imetelstat, which had a phase 3 study that showed positive responses last year, as well as luspatercept, which has now had a phase 3 randomized study comparing it to our traditional therapy of EPO, erythropoietin-stimulating agents in the front line of low-risk MDS. And so there's a lot of updates and a lot of more options, really, I would say, for patients with low-risk MDS that present more opportunity to control your disease and have improved quality of life during therapy.
Yeah, that's fantastic. And I think that just to emphasize that key point you mentioned, that there are more potential options and existing options for lower risk MDS than we've ever had before. And so while anemia and fatigue are the predominant symptoms our patients face, we know that this is just the beginning of the story. We're trying to figure out ways and think about how can we sequence and strategize who gets what first, who gets what next. And I think because we're seeing some exciting safety, efficacy, and impact on how patients are doing, I think that there's probably some interest in the field, and you might speak to this more in your debate session, of how we could slowly move some of these lower risk drugs into the stage right before MDS develops, or the clonal cytopenias of undetermined significance, the pre-MDS arena. Like, are there opportunities potentially for some of these drugs to try to prevent progression of MDS and so forth? And I think that our patients might be looking forward to how we might try to prevent MDS in the future. So I think these are just some small steps. What do you think?
Absolutely. We're at a point where we have so much better knowledge of the biology and the expected course of a given MDS diagnosis. We can much more understand how one person's MDS may differ from another's, and also what interventions might be most meaningful for patients. And that extends to people who have perhaps a precursor mutation that causes clonal hematopoiesis and that they might be at risk for MDS, but also for other things like cardiovascular risk or other complications that will impact their lives. Because in the end, our goal is to try to find ways to improve the lives of our patients and to be honest, for them to not have to see me so much.
Right.
And so as we develop these new drugs that are well tolerated, that have an impact on disease, that allow people to go back to their regular lifestyle, how can we build on that momentum and look at new disease populations like CCUS or CHIP, as well as look at optimizing our current treatment strategies.